Welcome back. This is video 3.2 on the rhythm series. In this video, we're going to talk about tachycardias that arise from above the ventricles and are largely irregular in nature. The tachycardias that arise from above the ventricles and that are mostly irregular in nature, and by irregular we're referring to the irregularity between the R to R intervals, are going to be atrial fibrillation and then multifocal atrial tachycardia. First is atrial fibrillation, which is fairly common and of great clinical consequence. In atrial fibrillation, there are numerous ectopic foci stationed throughout the atria, and because of some underlying disease process, and sometimes in people with structurally normal hearts, all of these ectopic foci start trying to discharge almost at the same time. Consequently, the atria can produce rates in the 400s and 500s in terms of fibrillatory waves. Now, luckily, not all of those impulses get transmitted through the AV node, and so we can think of atrial fibrillation as having an atrial rate, which is always extremely fast, and then a ventricular response, which can be fast and can be controlled. In the normal atria, we know that the sinoatrial node sends out a concentric impulse that allows the atria to depolarize and contract in a fairly organized fashion. This organized contraction allows for effective discharge of blood into the ventricles. When you do not have organized electrical activity in the atria, you lose this effective atrial contraction, and so you lose what we call atrial kick. Atrial kick is the final topping off of the ventricle as a result of contraction of the atria that helps to preload the heart with a little bit extra blood and then increase cardiac output by the Frank-Starling mechanism. If your electrical activity is not intact and you don't have good contraction, then you're not going to be able to establish atrial kick, and so your cardiac output can come down, which is a problem if you're already having a failing heart. Also, this lack of effective atrial contraction disrupts laminar blood flow. Normally, blood will enter into the atrium and then come out of the atrium in a more or less organized and laminar way. When the atria are in fibrillation, that lack of effective contraction disrupts the laminar blood flow, and so blood can seep into the left atrial appendage, become a clot. The clot can become discharged into the aorta and then consequently go up and create a thromboembolic stroke. As you can see on the left in panel A, there is no organized atrial activity. We see variable R to R intervals, and when we look for P waves on the baseline, we're not going to see any organized P waves. These are fibrillatory waves, these numerous hundreds and hundreds of atrial ectopic foci, all discharging, trying to compete for entrance into the AV node. Now, the ventricular response, as we have mentioned, is going to be irregularly irregular. Well, what does that mean? Well, regularly regular would be something like atrial bigeminy, so that we have a QRS complex and then we have a beat every other beat. It's an irregularity, but it's one that's very predictable or regular. Here, these R to R intervals are all over the place. You'll have long, you'll have short, you'll have long, long, short, and so they are irregularly irregular. Let's take a look at this 12-lead EKG. If we come down here to lead 2 rhythm strip to identify our rate, here we can find a QRS complex that falls right on the hatch mark. We'll do our count, 300, 150. This appears to be one small box faster, so a rate of something like 160. However, if we come down here, for example, here we can see this one's almost on the hatch mark, and if we do our count here, we've got 300, 150, 100, and so this one's something more like 120. What I would say is that it's between 120, 160, and highly variable, and then of course we would just look at the monitor from here on out. Next up is rhythm. Again, here we can look in lead 2, and we're looking for, this is the lead 2 rhythm strip, and we're looking for distinct P wave morphologies. So if we start here, there's a little bit of a hump here, but nothing that really looks like a P wave. Here, that's a T wave. That could be a T wave, it's hard to say. When the rate slows out here, there's really nothing before this complex, and not much here, and just a little bit of irregular baseline here. We do not see any organized atrial activity in lead 2. We don't see any in AVR. Now, we do notice that the R to R intervals are irregularly irregular. They're short, 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 long, short, 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 long, and so on. Now, if we come up to V1, that's right up there by the atria, and sometimes it can give us a little bird's eye view into the atrial activity. And so if we look in V1, what we can see are these tiny little fibrillatory waves When we take all of this together, that we have a fast rate, it's narrow complex, it's irregularly irregular with no organized atrial activity, this is of course going to be atrial fibrillation. Now, on the matter of these coarse fibrillatory waves, sometimes people will look at those coarse fibrillatory waves and think that it's atrial flutter. And sometimes we do have a situation where people are asking, is this atrial fibrillation or atrial flutter? And there are a couple of ways to help distinguish these. On the left, in the lower hand corner, you have an atrial flutter, and on the right, you've got an AFib. And the first thing that's going to be different is that in atrial flutter, the P waves, these flutter wave morphologies indicated by the capital F, are going to be pretty uniform in appearance and uniform in their spacing. That is to say, if we put calipers right here and right here, we expect the apex of all of those sawtooth P waves to march right out. Additionally, if we look at the area between these two waves, it'll be uniformly greater than 180 milliseconds. Now, that one's not as impressive as the spacing and identical appearance. Now, lastly, if you look over here, we have a QRS complex that's almost on the hatch mark, so let's count our rate. 300, 150, 100, 75, 60, 50, 43. That is exactly on one of the more bradycardic hallmark heart rates that we use when we're counting heart rates, which I just did. Whenever we see clustering of the ventricular response around those hallmark heart rates, we should think that could be atrial flutter. We can see, of course, here this sawtooth baseline, but also we can see clearly that if this is a T wave, then we've got 1, 2, 3, 4 P waves at that 4-to-1 ratio. Over here on the atrial fibrillation side, we can see that it is irregularly irregular. We cannot see any distinct and organized P waves. If we tried to measure intervals, they would be completely irregular because of the very nature of these atrial fibrillatory waves. And so that is a pretty good way to try to keep atrial fibrillation and a flutter straight. What I'd like for you to notice about this strip of atrial fibrillation that was taken in lead 2 is the smooth baseline. Sometimes if patients have been in atrial fibrillation for a prolonged period of time, particularly if they have concomitant COPD and so they have large AP chest diameter, the voltage of those fibrillatory waves may not show up very well. And then, of course, the longer that they're in that rhythm, it may become a little bit more regular in appearance. So just keep that in mind. And then also with this strip, you can look and see that the heart rate is probably around 60. You may want to say something like, well, isn't this junctional escape rhythm? Well, the rhythm rate is pretty close, but if we put some calipers on this, what we would be able to see is that there is an irregularly irregular rhythm. So if this were going to be a junctional rhythm that is regular, we should see this QRS complex matching up with the far side of this caliper. And then, of course, you can see very clearly that there's an irregular interval between these two beats. So this is atrial fibrillation, and so the point here is that even if you can't see distinct fibrillatory waves, and even if it's not tachycardic, you can still have atrial fibrillation, particularly if the patient has been treated with antiarrhythmics or with calcium channel blockers or whatever, which is blunting the ventricular response. Next up, for tachycardias that arise from above the ventricles that are irregular in nature, is multifocal atrial tachycardia. In multifocal atrial tachycardia, or MAT, there are multiple ectopic foci, just like with atrial fibrillation, stationed around the atria. However, these take on a little bit more organization. Consequently, these are capable of generating 3 or more distinct P wave morphologies. Now, because these P waves are coming from all of these various ectopic foci, we are still going to see an irregularly irregular rhythm. Now, in terms of medical history, we frequently see this in folks with associated lung disease. If we look at this 12 lead and we look first at rate, we're going to be able to just eyeball this and see that it's probably around 150, a little slower and a little faster in some places. When we go for rhythm, when we look at the lead 2 rhythm strip, we're going to see these arrows are pointing at P wave morphologies. Here is one that looks pretty regular in appearance. Here's one that is sharp and pointy. Here's one that is pointy but less tall, and then here is one that is upside down. So here we have narrow complex, irregularly irregular tachycardia, and then we've got 3 P wave morphologies. That, of course, is multifocal atrial tachycardia. This one's even a little more straightforward. Let's look at the rate here. Again, this is going to be somewhere around 150, but highly variable because of the irregularly irregular R-to-R intervals. If we look for rhythm and we go to lead 2, we can see a P wave here, one that is more narrow and sharp, one that is very tall and pointy, and then a couple that are slightly less tall but pointy nevertheless. Here we have, again, 3 or more P wave morphologies, multifocal atrial tachycardia. Next up is going to be rhythm. In the 3.3 series, we're going to look at ventricular tachycardia and ventricular fibrillation.